PaO2. We look at the PaO2. We look at the PaO2 being the oxygen. We look at the I'm sorry, y'all, I didn't mean to start. Thought everybody was in here. Okay, so we look at the PaCO2. We look at the carbon dioxide. We look at the pH in the blood. We look at the HCO3. We look at the SpO2. In older adult, values may be slightly lower, 95% to 100% in the O2. So let's look a little bit at the PaO2. Let's look at that. Elevations may indicate the possible excessive oxygen administration. These patients may be getting too much oxygen. Decreased levels may indicate a possible COPD, asthma, chronic bronchitis, cancer of the bronchi and lungs, cancer of the bronchi and lungs. If it's elevated, if the oxygen level is elevated with the ABG, you may see it in cystic fibrosis patients. If they're in respiratory distress syndrome, if they're anemic. Atelectasis, if they have atelectasis, or other causes of hypoxia. So y'all know how it works when we do test questions, right? Knowing what happens to the patient if it's elevated, you know what you'll see. And sometimes that's how the questions read, you know, when you get to the point of where you figure out, you know, how these test questions go. It's like, okay, if it's elevated, what am I going to see? So that's the reason why I bring out the what am I going to see things. So that when you look at, you know, test questions, you can say, I need to know what my value is. It's important to know what the value is, but if this number is high, what might it be an indication of? You know, what's going on with the patient? So those are some indications, and more so we look at COPD and pneumonia and that kind of thing with those. I'm sorry, COPD and asthma and chronic bronchitis. So let's look at PaCO2. Let's look at the carbon dioxide here. So if they got a lot of carbon dioxide, elevations could indicate COPD. In that instance, it could indicate asthma or pneumonia. It may even show a use of opioids. If you work in the ER and there's a patient that come in and that patient is in arrest or something like that, doc orders all of these labs and ABGs happen to be one of them. And if maybe a family member is with them and they say that they have no drug use, you could see that. That information may be available to you there to show that they may be, there may be some drugs in the system, along with during your drug screens and such. So that may be an indicator to help with that. Let's see what's important in here. We're going to look at arterial. Let's look at the pulse ox. So for us as nurses, this is the easiest thing we can do. And we talked about restlessness being a first sign of something going on with patients who have are deprived of oxygen. Your pulse oximeter identifies hemoglobin saturation with oxygen. How much saturation or how much oxygen has saturated or covered that oxygen. Usually hemoglobin is almost 100% saturated with oxygen. So when you put that pulse ox on that patient, and sometimes it'll show a 99, 98, 96, something like that, it can be almost 100%. I don't think I've ever put one on a patient and gotten 100. Have y'all? Mm-hmm. You have? Really? That patient must have been doing good, breathing in and breathing out. Now you'll notice too, if a patient has a pulse oximeter on and you ask them to take some deep breaths in and out, your numbers can go up too. That's something I don't know if y'all realize, but it does happen that way. Where can you put your pulse ox?
Anywhere. good perfusion.
Oh yeah, fingers, toes, nose, earlobe, forehead, all of those places you can use in order to get your numbers that you need. Your pulse oximeter can detect DSATs before symptoms. That's important, important, important. A lot of times, the doctor doesn't have an order for an order for a pulse ox, but if you go and check it and it's low, you gotta do something. You gotta do something about it. But yeah, that's your first indicator. You'll see dusky skin, pale mucous membranes. There'll be blue nail beds. And all of those things can lead you to say, okay, well maybe I need to check a pulse ox. Okay? But keep in mind, there are other things that can cause the pulse ox to read low, right? We know this because we've already talked about it, and the patient moving around. That could be an issue. So we might want to try to help them to stay steady, especially if they're elderly and they have a little bit of a tremor. So we might need to keep them a little steady. Okay, so we also know that if a patient has hypothermia, they may have a low reading. If they have decreased peripheral blood flow, sometimes if the blood flow is not good. If the patient has on fingernail polish, a lot of times we talk to them and we may have to get the fingernail polish off of one of the little fingers, so when we go and check them, we can get a good reading, okay? In the home, we may want to educate our patients if we're doing home health that if you wear fingernail polish, because what I used to do is I had a couple of pulse ox that I would keep with me, and if I had a patient that had some kind of respiratory problem, I'd give them one and teach them, how to check their pulse ox and everything if they didn't have one at home, and then, explain to them if you have fingernail polish or something like that on to not use it on that finger or take that fingernail polish off. So that's a good little teaching thing that we can talk to them about. That's basically it that I want to say about a pulse ox. Y'all already know about a pulse ox and its importance and what it can do. I think I want to go and talk to you, and we talked about a VT scan. I think I want to talk about a bronchoscopy. Let's go on to bronchoscopies. So we got a bronchoscopy, and what happens, it is the insertion of a tube into the airway as far as the secondary bronchi. The doctor's going to go down and look as far as the secondary bronchi. You know how when you go down and you look at the lungs, you have that big bronchi, and then they taper off. One goes this way, one goes this way. So he's going to go as far as the second one. Okay? So he goes down in there, and he uses it to diagnose and manage the patient's pulmonary disorders. So he does this so he can see how he best needs to manage that patient. Rigid bronchoscopy usually requires general anesthesia. If they're going to use one of those rigid, hard tubes to go down, they'll put the patient to sleep. Okay, and they'll do it in the operating room. If it's the flexible bronchoscopy, I think we may have looked at this. I don't know if we'll get to do it this year, but we looked at a video that actually showed a man getting a bronchoscopy done, and he was just having it done just to see how it works, and it helped us. So a flexible bronchoscopy can be performed in ICU or in a special endoscopy suite, okay? And they don't have to have a lot of sedation. Usually the doctor will probably give them something like Versed or something like that, and the patient will be talking out of their head, and they're, or trying to talk, or kind of giggly or something like that, and especially after the fact. So it is used to evaluate the airway and to help with the placing or changing of an endotracheal tube. If they do the flexible, it can help with changing an ET tube, okay? They can also collect specimens. They can collect specimens when they do it with in the ICU or special endoscopy unit. They can also use it to and get diagnosis on infections. A lot of times they go down and they'll clip, sometimes they'll clip a little bit of tissue and they'll send it off to the lab. Okay? What do we need to do with the patient? How do we need to discuss to them what's going on? We need to explain the procedure to the patient and verify that consent for the procedure was obtained. Why? Because this is an invasive procedure, right? So we need to get signed consent. Okay, we need to talk to them about expected outcomes, risk and benefits of the procedure, and we need to do that with the doctor. Let him talk to them, let them know. We need to reinforce what he has said to the patient. Okay? We need to document the patient allergies. It's important for us to do that. We need to know what other tests may have been performed or what we need to get, what other tests need to be performed, such as a CBC, a platelet count. We may need to do a PT. We may need to look at electrolytes, and we may need to look at a chest x-ray. Okay. Very important, we need to let them know that they need to be in PO for 4 to 8 hours before the procedure. Why? Aspiration, absolutely. We don't want them to aspirate on us. Okay. Now, when we do this procedure, we're going to also tell this patient that they're going to have like a benzocaine, some type of lidocaine spray in the throat so that they won't have issues when we're going down with the tube, especially if they're slightly sedated with some Versed or something of that nature. They'll still have that ability to be able to feel when that tube is going down. So we're going to numb them up. Okay? This agent reduces what we call methanoglobuleminemia. And I can't say that word. Look it up. It's on page 525. Okay. So the normal blood levels, okay, we're not going to get into that. Y'all don't need to know all that. What I do need y'all to know is the procedure can be done in a bronchoscopy suite, or it can be done in ICU, in the ICU bedside. Okay? The bronchoscope is inserted through either the nares or the oral pharynx. Okay, we need to maintain IV access for sure and continuously monitor the patient's blood pressure, respiratory rate, and oxygen saturation. Okay. Follow-up care. This is the stuff that we need to know for sure. Whenever they come back after they've had this procedure, we're going to monitor the patient until the effects of the sedation have resolved. Wouldn't it be funny if we could record? And we need to definitely make sure we know when the gag reflex comes back. So just in case they want to get something to drink, because usually after that tube goes down, they have that sensation, you know, where they want to constantly clearing their throat and stuff. It's because it's been irritated in that throat area. So we want to make sure that the gag reflex has returned before we give them anything to drink or eat. Okay. We're also checking their breath sounds every 15 minutes for at least 2 hours. Bleeding may be an issue, so we want to assess for bleeding. So we also have a thoracentesis. See, we got a lot of stuff on thoracentesis. Patient preparation is essential before a thoracentesis to ensure cooperation during the procedure and prevent complications. Tell the patient to expect a stinging sensation from the local anesthetic agent and a feeling of pressure when the needle is pushed through the posterior chest. Stress the importance of not moving. This patient should not move. They should not cough. They should not deep breathe during the procedure to avoid puncturing the pleura or the lung. This is a procedure that I would really be nervous about having, sounds like. Ask the patient about their allergies to local anesthetic agents. and verify your consent. This is another procedure that requires consent. So in endoscopy, if they're going to endoscopy, we need to know that they've had consent signed for a bronchoscopy and a thoracentesis. Okay? The thing about a thoracentesis, though, is that it can be performed at the bedside. So you may have an opportunity to be able to sit in or help with a thoracentesis. So it's a good thing to know. We don't know everything. Always understand, and this is something that I want nurses to know for sure, is that it is okay not to know how to do a procedure. That's why they have reference books on the unit. Okay? So if a doc calls up and he has an order and he says that he needs to he's going to do this at the bedside or do a thoracentesis, get your reference books and get your seasoned nurses who have been there. They can help you to be able to get the kits and stuff that you'll need in order to have available at the bedside. Because when that doc comes up on the floor, he's going to be waiting and ready for you to have everything there that he needs in order to go ahead and do what he needs to do. So there is no shame in not knowing what needs to be done. Just know that you have the references there. That's a safe nurse. That you know you have the references and don't feel embarrassed or ashamed about having to go and look it up. Because no one expects you to know everything. And now I'm off my soapbox. Okay. So ask the patient about the allergies, get the signed consent. The procedure for the thoracentesis is often performed at the bedside. A nurse practitioner or a physician, okay, will do it. Or although a CT or ultrasound may be used to guide it, the person performing the procedure and any assistants should wear goggles, because sometimes there may be some fluid that may escape. Okay, we don't want pleural fluid in our eyes or in our mouth or anything like that. So we know that when we do this procedure, we're probably going to need to have some goggles there once we gather our equipment, right? Get some goggles. After the skin is prepped, a local anesthetic is injected into the selected site. Okay, so the doctor's going to put the anesthetic on the back and he's going to get ready to do it. Keep the patient informed of the procedure while observing. You're going to do, this is your job right here. You're going to observe that patient and make sure they're not going into shock, okay? Because the doctor's going into the back. They're going in there, and we don't want them to go into shock. We don't want them to have any pain. We want them to be numbed up enough that they don't have pain. We want to look for any nausea. If they start to have nausea, then they're going to move, right? So we don't want them to move. We look at the skin color. Is there any changes in the skin color? Are they becoming diaphoretic? Are they sweaty? Cyanosis. Okay, we'll see that in the lips sometimes. They're getting cyanotic. Tachypnea. Okay, we're monitoring the blood pressure. We're monitoring all of these things that we need to be looking at. Are they becoming short of breath? That's important for us to know as nurses, the things that we need to monitor, okay? So keep that in mind. After the procedure is done, a chest x-ray is performed to rule out a possible pneumothorax. Okay? The doctor's going to look. This is follow-up care. After he does this, he may order or he will order a chest x-ray to rule out a pneumothorax and a mediastinal shift. Okay, so we get into that when we start talking about a hemothorax, a pneumothorax, and all of that stuff, because the mediastinal shift can happen in those instances. Okay? So a shift of the central thorax structures, what will happen is it moves to one side. It moves to one side. So we monitor vital signs. Okay? We listen to lungs for absent sounds. Okay, that means that that lung may have collapsed or something like that. So we listen for that. Okay, we check the puncture site. We check the dressing for leakage. We want to check it for leakage. Those are the things that us as nurses have to do. Okay, we assess for complications such as a reaccumulation of fluid in the pleural space. Subcutaneous emphysema, like the subcutaneous, you'll hear that crackling noise. And that comes with chest tubes. We'll talk about that with chest tubes as well. Infection and tension pneumothorax. All of that in that little bucket. So we need to urge the patient to deep breathe because we want to make sure we keep those lungs expand, okay? We want to ask them to deep breathe. This is going to promote that lung expansion. And we are going to document everything from the time we got that order to the time we finished and to the time that patient tolerated procedure well. For sure. That is important. Teach the patient about the symptoms of a pneumothorax. We need to let them know that they need to tell us if they're having pain on the affected side. Okay, if it gets worse when they inhale. We need to ask them, or we need to check for a rapid heart rate, shallow breathing, any feelings of air hunger is important. So that's as much as I want to say about that. So we're going to talk about a lung biopsy because I think we talked a little bit about lung cancer. So a lung biopsy, is it on here? Yeah, biopsies. Lung biopsy. On a lung biopsy, it is performed to obtain tissue for histologic analysis for cultures or cystologic examination. Histologic or cystologic? Cystologic. The samples are used to make a definite diagnosis. So if I get a lung biopsy, it's going to make a definite diagnosis of inflammation, cancer, infection, or lung disease. A lot of times when a person comes in and they have a CT scan done or something of that nature, and then the doctor sees something on the scan, then he'll want to go ahead and do a biopsy to test and see what that tissue, what's really going on with that tissue. A lot of times when a doctor figures there is some kind of cancer going on, he's going to get them pretty quick. You'll find these patients that are in, sometimes they have a scan done, next 2 or 3 days, they're talking to the patient, next 2 or 3 days they're in and they're having a biopsy, and the next 2 or 3 days they're in and they're having a surgery. So we try to move quick on situations like that. So the patient, how are we going to prepare them? The patient may worry about the outcome of the biopsy. That's normal. If you see something, any of us, if we've had a scan done and the doctor says that I see something, maybe if we had a pap smear and they call you back and they tell you that they see abnormal cells or something like that, you worry. Because you want to know. Every time you get that call and say it's time to have a mammogram done, you worry. Because you don't want them to tell you that there's something wrong. Okay, so we need to talk to the patients about it. We need to explain to them what's going to happen, and we need to be prepared to accept and listen to them. Not just say, hey, I'm here for you, I got to go. If you're going to talk to them and let them know. And I guess it comes from working on a cancer floor, in that we were allowed to have all that time to be able to spend with the patient, especially newly diagnosed, walking through, seeing a young, healthy man come in with cancer and dying. I mean, his body just deteriorated to the point of where we're looking at him with no hair, lost all of his weight. I mean, it was a hard thing to see. But when you work in a unit that takes care of patients that have cancer, that's a special thing. That's a real special calling. So, but yeah, I mean, you have to be prepared to sit there with them and talk to them and counsel with them and try to understand, help family members understand. It's a process, So, with the lung cancer, the procedure, it's a percutaneous lung biopsy. Biopsy is usually what they perform, okay? It's done in the radiology department, and we have to get informed consent. Always know that if they're going to do anything that's invasive, we have to get informed consent. So for us, our follow-up care for these patients is going to be that we're going to check their vital signs, Okay, we're gonna listen to breath sounds. This is what we do after the patient has had a biopsy. Okay, and we're gonna check every 4 hours. Check them every 4 hours for 24 hours. Why are we doing this? We just took a chunk out of somebody's lung, right? So if we took a chunk out of their lung, what could possibly be a problem for them?
They're at risk for tension pneumo and hemopneumo.
Possibly. But also, they would have respiratory distress. They might go into respiratory distress because we've taken a part of them, we've taken something from them. And if it is a tumor in there, it probably was causing issues anyway. But the fact that we've removed that portion of that lung, then there could come other issues. So we look for that. We look for shortness of breath. We look for pallor. When we go in there, we look and make sure that they're not breathing hard. We look at their skin to see if they're sweaty. You know, we need to do that. We need to take that moment and do that because so easily these patients can crash on us. We look for tachypnea. A pneumothorax is a serious complication of a needle biopsy. Remember that. A pneumothorax is a serious complication of a needle biopsy. And we certainly don't want to end up having to throw a chest tube. Okay? So let's do what we got to do at first. Well, sometimes we can't help it. But, you know, we may end up with a chest tube. Who knows? So let's see. Do we want to get into oxygen? I believe we can. We can get into oxygen therapy and talk about that. So a Venturi mask is one of the ones that we're going to talk about. What I think we're going to cover really mostly on the oxygen therapy, because you all really know already what oxygen therapy, what masks do, what we use them for and such. I want to get into the high flow, low flow type situation and kind of compare and contrast the two. So let's see if we can do that. Let's start with our low flows. So our low flows are going to be those oxygen delivery items such as our nasal cannula. That's considered low flow. A simple mask. A simple mask is low flow. A partial rebreather mask is a low flow. And a non-rebreather mask is low flow. Now, for us as nurses, what are we going to look for? We are going to encourage with a nasal cannula. We always want to make sure that the prongs are in the patient's nose properly, that they're wearing it properly. Why? Because a poor fitting nasal cannula can lead to hypoxemia. A lot of times you go in there, especially back in the day when we went to the nursing home and you see the patient with the oxygen sitting up here on the head, or they got it in their mouth, or they got it sitting over here to the side, or it's kind of hanging out one nostril. They're not getting enough oxygen, so they could end up in a hypoxemic state. So we need to be aware of that. We need to check for skin breakdown. We've heard this 1,000 times, but it's important that we need to make sure that they're not having any skin breakdown. They can have breakdown around here, around the face, around behind the ears. They can have breakdown right up under the neck. There's so many different places that they can have issues, and especially this is important to discuss with family members when they go home, especially if they're new to oxygen going home. And their skin's being so delicate, we need to make sure families understand that they need to take care of that and use water-soluble jellies if they need to around theirs. We don't want to tell them to get some Vaseline. We want to tell them to make sure to use something that's water-soluble. Okay? Why do we do that? Because it's going to help prevent irritation. Okay? And the other thing, too, about petroleum jelly, when you think about it, I mean, you got oxygen, you got petroleum jelly, and then what if you got somebody who still smokes? You could really end up with a concoction here that could cause you to have a totally different face before it's over with. Okay? So, we think about how we're going to deliver this oxygen if they have a nasal cannula, and we already know that if they are getting a certain level of oxygen up to 6 liters or so or something like that, we can keep them on a nasal cannula and it'll be okay. We can do that. So if a simple mask is ordered, if they order just a simple mask, we go over the face. Be sure the mask fits properly. Same deal. We want to make sure that everything is fitting properly and that we are checking around the face, around the nose area, around the bridge of the nose, just to make sure, we do good care and keep their skin intact. And we don't need to talk about a partial rebreather, just knowing that those are the ones that are low flow. And a non-rebreather is a low flow. So what I did want to talk about is a high flow oxygen delivery system. Okay. A Venturi mask, an aerosol mask, a face tint, a Vapotherm high flow nasal cannula, a trach collar, and a T-piece. What the heck? What's that? Sounds like someone about to fall in, huh? These devices deliver an accurate oxygen level. That's why doctors want to use a high flow. If they need to use it, they want to make sure they get an accurate oxygen amount to the patient, okay? Our job is to make sure they fit proper. We'll make sure they fit proper, okay? So on a Venturi mask, okay, we want to watch the patient constantly, constant surveillance, okay, to ensure that accurate flow rate is going to the patient. Why? Because an accurate flow rate ensures that they're going to get enough O2 delivery. That's the whole point of that. We just need to make sure that it's on there good, that the patient is getting a good amount of oxygen. Usually they're going to set them up with 4 to 10 liters, okay, with high humidity. So they're going to have some kind of humidification going on if they got a high flow. Assess, but we still assess for dry mucous membranes. We need to do that. Even though they've got some humidification, we need to check and make sure that they are not drying out. What if this patient is wearing a mask and they need to eat? What can we do?
Put a nasal cannula on?
Absolutely. We can change it to a nasal cannula, and you can do that because a Venturi mask will go from 4 to 10 liters. So if it goes from 4 to 10 liters, we can safely put them on a nasal cannula to let them eat. So yeah, that's something that we can do, we don't have to wig out and say, oh, snap, I gotta call the doctor because of this or that. No, we can do that. Let's see. I don't want to get this thing too loud. Let's see. So, an aerosol mask and a face tint and a trach collar. Okay. We're going to assess the aerosol mist escapes from the vents of the delivery system during inspiration and expiration. Assess that aerosol mist. Like when you go in ICU and you see them set up and they are connected to all the stuff, you see that mist coming up and out. So you want to make sure that it's actually doing that. It needs to be doing that. Humidification should be delivered to the patient is because we need that humidification. We need to see that there's actually that mist coming out of there and that they're getting that. That's the most important thing to remember about these particular masks is making sure that they're humidified, that they're getting what they need there. In a T-piece, however, if they're wearing a T-piece, we want to make sure that we empty the condensation from the tubing. It's important to get that condensation out of there. We don't want it to build up. Why? Because it interferes with the rate, the delivery of the oxygen. Okay? Which this condensation may get into the trach. We don't want that to happen if it's not empty. So that wetness getting into the trach is no, it's no good. We don't want that to happen, so we need to empty it, okay? All right. Now, I am done for the day. No, I'm gonna let y'all go. That's all I can do for now. I need to regroup. My throat is starting to hurt. We'll talk again after lunch. after y'all test. Yes, so I'll let y'all have this time to study for tests or whatever you wanna do, get your mind